Everyone, we're going to get started here. We're very excited to kick off Grand Rounds today with this awesome talk from Dr. Bacon and Dr. Spinelli. Dr. Spinelli is an assistant professor in our division. He's also the clinical lead of the PrEP program at Ward 86. And Dr. Bacon is the medical director of City Clinic and also a volunteer associate professor at UCSF. Their talk is called Be Prepared, HIV PrEP Cases, both from Ward 86 and from City Clinic. And Dr. Spinelli will start us off.
Okay, great. Well, this first case actually spans both City Clinic and Ward 86, so it's very apt for this theme. And this first case, I think an important topic worth focusing on is starting PrEP among people who inject drugs. So this is a 37-year-old man who drops in at City Clinic in 2013, and that's 2023, sorry, I was tired. It's pretty early, yeah, he was on the cutting edge of PrEP. Was approved, but okay, due to desire to start PrEP, but definitely not doxyPEP was not available. He endorses smoked and IV meth use. He does tell you he uses clean needles and reports condomless sex with men. He'd like to start PrEP, but he does not think he can take a daily pill or do an injection. He has a pretty busy life. He's a DJ. There's a lot of partying. He has a really hard time remembering to take pills. He had not heard of PrEP 2-in-1. He does endorse dysuria, and in City Clinic is diagnosed with NGU, non-gonococcal urethritis. So what PrEP agent would you offer this individual? This is for your, I hope this looks like it's programmed, I can't tell. Okay, A is FTDF daily, FTDF 2-in-1 on-demand dosing, FTAF daily, FTAF 2-in-1, and or injectable cabotegravir. Can anyone shout out what the website is for the poll? PolEv/HIVGR. How you forget, polev.com/HIVGR. And go forward. Okay, here we go. How quickly you forget, Liz? Okay. All right, give it another second. Maybe I didn't highlight. He says he does not want to do injections. So maybe you'll still do it, but okay. So F 2-in-1, I think, would be the right option for him. And we'll talk about sort of the nuances of that in this individual who cannot take a daily pill, but does not want to do injections at this point. So a few reminders in case this tripped you up. PrEP is for any sexually active individual or those who share injection equipment. People who inject drugs often have concomitant sexual exposures. All sexually active persons should have PrEP discussed and considered as an option. The old paradigm of where we were thinking about this balance between the benefits of PrEP and the risks of PrEP, which are very minor, really emphasize these risk criteria and screening tools, which we've now learned over the last 10 years have been counterproductive and stigmatizing. So this is our current landscape. I think soon to change. It feels like now it changes every year. But these are the populations that have been studied for each of the options. 2-in-1 oral TDF-FTC only ever studied in cisgender men in France and Montreal, and a few transgender women. Never studied among people who inject drugs. Daily oral TDF-FTC remains the only option that's been studied in every population, although that may change soon. Okay. This is an aside to talk about the stimulant use epidemic. In the 80s and 90s, huge increases in stimulant use, the crack epidemic. Then in the 2000s, we had a decline. 2000s were a nice era, huh? Y2K, we thought some trepidation. Turned out the vibes were mostly good. But resurgent stimulant epidemic, though, in the last 20 years among men who have sex with men, as high as 5 to 30% in some studies. One of my collaborators, Christian Grove, has a national cohort of sexual minority and men who have sex with men. And in his sample, 12% have stimulant use, and 20% of those who use stimulants experienced an HIV seroconversion over 3 years. And this was 4 times the rate of non-stimulant using MSM. So this is really a priority population for both stimulant use treatment and PrEP efforts. I still, coming back to the slide, 2 years later, I still really like this. I think shared decision making in an era of more prepped options is really the way to do counseling about PrEP. I like this presentation that Christine Dellendorf and Nika Seidman, I'm forgetting which one of the two made this, but this is definitely pretty much my approach. Try to establish rapport, elicit people's preferences for what they're looking for in PrEP. That'll include things like their interest in daily pill taking, like for this gentleman. Are they willing to receive an injection? And it's not just the injection, it's also the medicalization of having to come into a clinic every 8 weeks that you have to weigh if that's something they can do. Leave the door open for change. I think that's all very important. So for this individual, I'd say, although daily FTDF has the best data for preventing both sexual and IV transmission of HIV, he wants to take oral PrEP. He doesn't want an injection, but he can't do a daily pill. So 2-in-1 is really the best option for this individual. This is a slide that I've also, I think, presented now for the third year, and I still like it. This is a modeling study looking at the HIV epidemic and what changes in PrEP modality and overall uptake. What will happen if you switch everyone from oral TDF-FTC to CAB-LA? You're only going to see an increased reduction from 35% over time to 37% over time. So although cabotegravir is superior, the absolute difference in effectiveness, rather than the relative difference, is actually still quite small. PrEP is effective no matter which agent you use. And this will be the same for lenacapavir, even though it looks amazingly effective. We're not going to move the needle if we switch everyone from oral to long-acting PrEP. We're going to move the needle if we expand PrEP uptake overall. Why haven't we really done that? Currently about 3% or 1%, depending on which data you read, of people who use PrEP are using long-acting cabotegravir. So this is currently not really moving the needle at all. And this was a helpful presentation from Rupa Patel, who also combines my other passion here of implementation science, showing us the barriers for uptake of cabotegravir in several domains. It's remedicalizing. You have to come into a clinic every 2 months. Maybe lenacapavir will help there. Policy level is a total mess. The buy and bill is a huge issue, where clinics have to spend thousands and thousands of dollars. These drugs are incredibly expensive, and then bill for them. That's just not an option for many clinics. And then, step therapy is a classic one for private insurance. You must fail oral therapy. What does that mean? If you already have HIV, that's not going to work. So organizations have a lot of problems implementing this. The space, are providers comfortable? Are PrEP users comfortable? Is leadership comfortable doing quite a high financial outlay to get this started? And the workflow is quite complex as well. Something we're doing at Word 86, and really proud of what we do, but I think we are unique in some ways, as much as I hate when reviewers say that. Okay, case one update. He elects to start 2-in-1, but doxy-PEP is delayed. He's actually eventually diagnosed with MGent. He does doxy followed by moxy, and then he's lost a follow-up. A year later, he comes back on the radar. He's referred to the Word 86 PrEP e-consult. Christy Camp reads it. He, 1 year later, and he wants to access PrEP and long-acting methamphetamine treatment. He recognizes now that his meth use is a problem and he can't take any oral therapies at all. He just forgets. His life's too chaotic. He wants something long-acting to treat his meth, and would do PrEP as well. So his main interest was actually, this is one of my patients, his main interest was actually in starting the long-acting naltrexone, which I think was great. And he said, if I'm using one injection, I might as well use the other for PrEP. He really saw his meth use as the much more pressing issue in his life rather than his risk of HIV. He never took PrEP 2-in-1. As we discussed, orals were really a challenge for him, but he's warmed up to the idea of injections because he knows that he just can't do pills. He just still denies sharing injection equipment. So what PrEP agent would you offer this individual? Would you do FTDF daily, 2-in-1, FTAF daily, FTAF 2-in-1, direct to inject cabotegravir, or would you do an oral lead-in and then injectable cabotegravir? People still like FTDF daily. Really, the Bangkok data being the only data of prevention of transmission by injection drug use. Some people like the oral lead-in. Almost everyone likes direct to inject. Okay, I agree with that. This is a reminder that there were seroconversions during the oral CAB lead-in HPTN-0A3. You're taking a population that doesn't really like to take pills and telling them they need to take a pill to assess safety. And some people just won't do it. And people who are seeking PrEP are generally at a moment in their life where they need PrEP. C2, as far as I can tell, I didn't want to contact Rafi right now, given what's going on in LA, but I believe C2, these are the people who seroconverted during the oral CAB lead-in HPTN-0A3, and HPTN-0A3 has been reclassified as a baseline injection. That is what I could gather from rereading the latest articles. In HPTN-0A3 Olay, 70% elected for direct to inject CAB, and overwhelmingly in the open label extension, people switched from oral TDF-FTC to CAB, almost everyone. In WAR86, 100% of people elect for direct to inject. And I think that's a reflection of the population we see here who really benefits from long-acting therapies. The Bangkok tenofovir study, or BTS, is our only data in the prevention of transmission through sharing injection equipment. BTS, by the way, is the name of their BART in Bangkok, so it was a cute title. This study was relatively large, 2,500 people. They were also receiving directly observed therapy with methadone. Most people, some people weren't, but I think 90% were getting DOT. So this was a very unique population that doesn't really reflect what this individual is going to receive. But as a reminder, I think I've said this 3 times, many people who inject drugs are also at risk sexually. So let's think a little bit outside the box. A lot of people highlight the relatively modest risk reduction in this study, 49% in spite of the DOT. However, when they did do drug levels, particularly people seroconverted, the drug levels were quite low. So what was going on with the DOT? I don't know. How are they not getting tenofovir in their system? Some things about this study still perplex me a little bit. But it does work to prevent transmission by sharing injection equipment. It just probably doesn't work as well. Okay, he had a negative HIV antigen antibody 1 month ago. What testing would you perform to get him started? Would you do a rapid? Provide if negative? Would you do a rapid plus an RNA? Provide when the rapid returns negative? Would you do a rapid HIV antigen antibody test? I'm sorry, I'm not referring to oral rapid tests. Or an HIV RNA? Would you provide when both tests return negative? Or would you do no additional testing? He was negative 1 month ago. Okay, some people want to do a rapid only. Most want to do both, but are not going to delay for the viral load. Great job, everyone. That's exactly what I would do too. I think it's important, particularly at initiation, to have the HIV viral load sent. We know from treatment and from many other settings that when people are seeking something from you, I mean, this is sort of like the model of Amazon too. When people want something, make sure they get it as quickly as possible, because if you don't do that, they're less likely to follow through. And we really want to make PrEP as easy as possible for people to start. That's the principle of rapid PrEP starts. For safety, though, in the rare situation where we've missed an acute HIV infection with the rapid test, we're going to get the RNA back in a few days anyway. We can respond. I think it's unlikely that cabotegravir resistance will develop in that shorter window, and we can get them on treatment. So this is our preferred approach at WAR86. The FDA and CDC guidelines support this. This is just a little bit about our injectable PrEP program, and I really do think that we are expanding the PrEP pie here. I'd like to see more people, but stuff is speeding up. 28% had no prior PrEP use, and 33% were not currently using PrEP. So we're really recruiting a population that would otherwise not be on PrEP with injectable therapy, and a population with more than half have either meth, opioid, hazardous opioid, meth, or hazardous alcohol use, or a severe mental health diagnosis. You know, and in spite of that, we're seeing great retention, 83%, 85% of our injections are on time using the FDA 7-day definition. So we're doing really well. We want to get people who have on PrEP who've never taken oral PrEP or who are not currently on oral PrEP. That's how we make an impact on the HIV epidemic. We think injectable PrEP is a great option for folks with housing instability and for substance use and mental health challenges. If we can provide multiple long-acting therapies at once, that's ideal. So the teaching points from this case, don't use sexual risk criteria to see if someone qualifies for PrEP. I provide PrEP to anyone who asks for it. I would use shared decision-making, meet people where they are, discuss all PrEP options. Many people who inject drugs are also exposed to HIV via sex. Beware of the worsening stimulant epidemic. And I see long-acting therapies as a great option for the people we serve here at San Francisco General, particularly those with adherence challenges. And we really need to be providing integrated care to serve this population. Okay. See, I'm doing good. Case 2. So this case is now we've got your patient on PrEP, so we're going to look a little bit at some of the more cutting edge issues with follow-up on PrEP. This one is focused more on exclusively on long-acting PrEP. So this 28-year-old man is currently on 2-on-1 PrEP. It's prescribed daily, and he's using FTAF as a 2-on-1 option. He presented to the health access point as he's interested in starting cabotegravir. This is also a patient I saw. Both FTDF and FTAF cause GI discomfort for him, and he's very anxious to be on an effective PrEP agent with fewer side effects. And that's why he's doing the FTAF 2-on-1. He originally switched to FTAF because his provider said maybe you'll have less GI side effects. Didn't work out for him, as the data suggests that the side effects are similar. So his last exposure was 3 days previously, for which he took the 2-on-1 dosing with FTAF. He denies fever, chills, rash, or other symptoms, and he wants to go direct to inject. So how would you handle his 2-on-1 FTAF use in transitioning to CAB-LA? Would you wait for a viral load, then start? Would you wait for a negative lab-based antigen antibody test, then start? With the viral load pending, would you wait for a negative rapid antigen antibody test, then start with labs pending? Would you administer big FTAF for 30 days, then transition if the viral load is negative at day 30? Or E, would you administer some TUSA for 30 days, then transition to CAB-LA if the lab-based antigen antibody test is negative at day 30? You guys were fast. I like to see that. Leading is a negative lab-based test, then start with the viral load pending. Some folks are thinking about doing PEP or however you want to call it in this case, since he's actually out of the PEP window, and then doing the viral load, thinking that he's at high risk and was on a potentially non-effective PrEP agent. And others want to just do the rapid test and then start with labs pending. So I would do C for this gentleman, similar to the first case. And I'll talk a little bit about that. So SimPrep is going to be testing FTAF 2-on-1. It's a relatively small study, unfortunately. 529 people, men who have sex with men in Thailand and France. The outcomes will include efficacy, acceptability, creatinine clearance, and body weight change. But until then, we don't have any data on 2-on-1 dosing of FTAF. And the concentrations are very high. So depending on how much you put into pharmacokinetic data, my suspicion is that this is going to work just fine. So that's what we did. And he starts CAB the same day with the rapid tests pending. And, you know, if you were in the rare case to have an acute HIV infection, I think we can respond in time. So that would be my justification for what we did here. You can see his testing and his injection intervals. Some are actually more than 7 days late, you'll note. And then on February 8th, 2024, he receives the result of detected less than 30 HIV viral load tests with a non-reactive antigen antibody test. And his point of care obviously was also negative. We do that at every visit. So what would you do with that? Is this likely a false positive? Would you continue his CAB-LA but do additional testing? Is this likely a false positive? Continue CAB-LA without additional testing? Would you start big FTAF, do more testing, start doing your COBE FTAF, do additional testing? Would you hold CAB-LA, encourage condoms and do additional testing? What do you guys think? A is favored. Some folks want to start treatment and treatment and do additional workup. And really overwhelmingly folks are going to do A. Okay, I agree with that. At the time, I was maybe less sure of that response because we didn't have the data from AIDS this summer. But that is what we did. So let's talk a little bit more about this. This is his results again with the detected less than 30. I don't know if Dr. Whitman is on Zoom or not, was very helpful on this case. A lot of times by the time our viral loads come back, the sample is still there, it's just frozen. So we only had enough sample left from the original to rerun the viral load. And that returned negative, but that was frozen. So maybe the sensitivity was decreased. This is a very low level positive. So we called the patient back, and he does come back a little bit later on the 13th. He gets a qualitative HIV RNA. Here you have to send that as a send out. You just do a miscellaneous order, but Jeff will approve them. And he's was also not detected on the quantitative test. His antigen antibody was non-reactive, and he's enrolled in the PrEP study. And aside that we're not going to focus on, one of the many PrEP assays he received also had a likely false positive, was similarly positive at a very low level, but it was one of, I think, 10 aliquots. Then, to make everything more confusing, on the 29th, he presents to urgent care with a viral syndrome. COVID-19 was negative, strep antigen and culture were negative, and influenza was negative. His results, I believe, if I'm remembering correctly, did not get HIV testing. And on the first, he does get tests. He comes back and gets a quantitative and qualitative HIV and RNA. Those are all negative. And we also send an HIV DNA at this point. And that you can also do, I believe that has to go to Quest. So that's also a send out. You got both for the qualitative and the HIV DNA. I would email Jeff Whitman if you're going to do that, but he'll approve it in these cases. So is this a case of long-acting early viral inhibition syndrome? A lot of talk about this in the last 2 years following Susan Eshelman's presentation at CROI in 2023. Acute HIV is generally the natural history of that is explosive viral replication. People tend to have symptoms, but not always. This usually can be detected with a fourth generation antigen antibody assay or an RNA assay. People tend not to have assay reversion. Transmission is likely during that phase. Levi syndrome is, kind of a more of a low level smoldering type infection. People tend to not have symptoms, and it's much harder to detect. You have to use more sensitive assays or get lucky and use a regular viral load. And transmission, we think, would be less likely. And then, unfortunately, resistance is common. This is the updated HBTN-083 data as of the most recent New England Journal article. And I mentioned the oral CAB lead-ins now only being 2, because one was reclassified as a baseline infection, which shows you this issue of Levi syndrome. So 6 individuals were infected despite on-time injections, and 3 after delayed, and 2 at reinitiation of CAB in the open label phase. What you should remember in this study, though, is that the definition of a late injection was much less stringent to what the FDA definition is. We consider people late if they were 4 weeks late. So the FDA, for whatever reasons, probably operational, made a late injection 7 days. So these are the cases. 10 of them, sorry, I'm stumbling. 18 of the cases had CAB exposure. 16 of them had more than 6 months since CAB exposure. And the only ones that got INSTI resistance had recent CAB exposure. This is an example of the case that she presented at CROI. This is how these can be so challenging. This individual, the qualitative RNA on retrospective testing had been positive 9 months prior to the actual diagnosis. And the regular HIV RNA was not positive. It was a single copy assay that detected 6 copies per ml. on the day the infection was detected, the viral load was only 23, and the discriminant antibody was actually positive, interestingly enough, not the antigen antibody. This case, I think she highlighted because of the way the assay goes from non-reactive to reactive in the antigen antibody test. The RNA also can go from negative to reactive. So either test, you can have challenges with diagnosis, although the RNA is more likely to catch things sooner. And they said potentially 8 of the 10 INSTI resistance cases could have been prevented with the RNA test, although I'm not totally sure which RNA tests they're referring to. This was the really key data here from this summer. In Germany, Rafi Landowitz presented data. This is just from the open label extension is really important to cite, because this is they weren't routinely doing HIV RNA testing in the blinded phase of the study. And if folks are exposed to cabotegravir within 6 months, a positive HIV RNA assay only has a 9% positive predictive value. So most positive RNA tests and people on CAB are going to be false positives. So that's really tough. If folks have not been exposed to CAB, the performance of the assay improves dramatically. This slide on the right also highlights that there are much more false positives in the non-US sites. So there might be something related to procedures and laboratories in some of the global sites that were in the study. Okay, let's just move forward. This is a really helpful slide for us here. This on the left are the false positives, and the right are the true positives. And the blues are people who, I don't know why it switched to purple, but the blues are people who have not had CAB-LA in 6 months, and the yellows are people who did. And you can see that the true positives more likely to have higher viral loads. None in the open label extension were at the limit of detection, like in the case from the blinded phase. In the blinded phase, I went back and I really tried to look at those little graphs. And to the best of my knowledge, I believe 2 of the true positives occurred at the limit of detection. And the D2, the one that she presented at CROI, that only would have been detected early with a qualitative RNA. I don't believe a quantitative HIV RNA assay would have detected that. This was also a case presented by a colleague, Dr. Anu Hazra, in Chicago at the Howard Brown clinics. And this individual had a viral load of 30. I believe that the cutoff of their assay is the Abbott one, that's 20. So very close to the limit of detection. And then the follow-up testing, it was right at 20. So these do happen in the real world. And this person did end up having HIV. So these cases are really challenging. This individual never started ART. He continues to receive cabotegravir. He actually just left our network and went to a private provider. Seems like he's going to be able to continue his CAB. His all subsequent viral load and antigen antibody testing has been negative. So this was truly a false positive. So I would say these cases are challenging. Just remember, long-acting PrEP has superior efficacy. These breakthrough cases are very rare, and it appears in women, they almost don't occur at all, possibly related to higher drug levels in women. But in these rare cases of breakthrough, the clinical management is very complicated. This Levi syndrome can occur because we initiated CAB-LA during an acute infection. Think about this like giving syphilis treatment. You're always getting the day of initiation viral load. Always get it. Always get the RPR the day you give the penicillin. Always get the viral load the day you start cabotegravir. It's just easier. And initiation is really the most important time. People tend to be in windows in their lives where they're at high risk. The breakthroughs that do occur, they can occur with adequate drug levels, or at least the way we define adequate drug levels. Stay tuned for that. That's something, a research project that Monica and I are interested in. Delayed cabotegravir injections can be a reason, and potential for poor adherence to the oral lead-in is another scenario that I think we prevent in our clinic by offering direct to inject. I think unless the person really wants an oral lead-in, or unless the person wants an oral lead-in, most people don't. Make sure direct to inject is an option for folks. Okay, should I check viral loads at follow-up? This is the big question. I think there was a lot of enthusiasm from removing this from the guidelines, and we all thought that was going to happen, and it never did. So I think there's a lot of debate occurring, and it's unclear what the CDC will recommend. Surveying colleagues, the opinions are quite mixed. I don't know if what Oliver has heard from talking to people. Always check at initiation, as we said, and I would always do it at late injections and reinitiations. We're going to put in our guidelines that at routine follow-up, it's optional. We're going to continue doing it for operational reasons. It's really hard to do it in some scenarios and not others, and I'm more worried about it not getting done in the people who really need it. But I am going to change my counseling. I am going to feel very comfortable telling a patient who has a less than 30 detected that this is almost certainly a false positive, but we want to make absolutely sure. If an HIV viral load is positive in your patient on CAB, I would contact seroprep.ucsf.edu. That's the website. And you could just Google seroprep. That's Dr. Kate Koss's really great study that's investigating these cases in depth. And I would retest, and I'd also call the lab to see if there's something left on the sample that flagged positive. And we are still sending a qualitative RNA and HIV DNA and repeating the regular testing in these cases. We've actually had 3, and all were false positives. All less than 30 detected, and all 3 were false positives. Okay. These are my acknowledgements. Thanks so much. And I think we'll hold questions to the end. I went a little long. Thanks, everyone.
Thanks, Matt. That was awesome. I'm going to take the podium privilege to ask you 2 questions. One is, do you do same-day starts with CAB at Ward 86? You guys are so lucky you have a pharmacy on your campus. Okay. All right.
Yeah, the Medicaid.
Yeah. Really helps us. Yeah. Because you can essentially buy and bill.
Yeah, sort of. I mean, without the financial
right.
benefit to our clinic.
Right.
Without the financial benefit.
Right.
Is it on?
Yeah.
It's on.
Okay. Yeah, we don't technically buy and bill, but because we have the pharmacy on campus,
but functionally,
and the Castro Mission site, they're very close to AHF, and so AHF can get them drug.
Yeah.
Usually in 24 hours. So it's sort of a rapid start.
We use AHF too, and they are amazing at getting us drug, but we can't do same day starts.
Right.
Unless we do something that's vaguely illegal that I'm not going to talk about. Okay, no comment. Thank you for the plug for getting RPR on the day of the first bicycle. I really appreciate that. All right. Oh boy. Okay, here we go. So here's another case. A 24-year-old HIV negative self-identified gay man on PrEP through a mail order service. I don't want to get an STD. No one wants to use a condom. This guy told me I should take doxycycline when I have sex. Do you think I should? This is what he says when he comes in to see you. He's had 6 male partners in the last 3 months. He tops and he bottoms. He gives and he receives fellatio. 9 months ago was the last time he had STI screening. 3-site GC and CT NATs were negative. HIV was negative, and the RPR was non-reactive. He did have pharyngeal gonorrhea 2 years ago. So what would you tell him about DoxyPEP? Option 1 is let's talk about it. It's called DoxyPEP, PEP, P for post. You take it after condomless sex or anal sex, not every day, unless that's how often you need it. Or you haven't had an STI in the last year, so I don't think the benefits outweigh the risks, especially the risks of developing drug-resistant bacteria and harming your gut microbiome. Yeah, that's a mouthful. Option 3 is, yes, you should definitely take it. You're just the kind of person they studied, and it will lower your risk of gonorrhea by 65%. Okay. Well, that was quick. That's what I would do too. So 100% of people said, let's discuss DoxyPEP. Great. Okay, so why do we need new STI prevention tools? So quick break for epidemiology. So for the last decade plus, the US has been experiencing skyrocketing and sustained rates of gonorrhea, chlamydia, and syphilis. And you know, some people will say, oh, they're just STIs, who really cares, they're curable, but they can have very serious consequences. And I think the most serious ones are untreated syphilis leading to neurosyphilis, ocular syphilis, otosyphilis, potentially leading to vision loss and hearing loss. I think scarring of the female reproductive tract, leading to infertility and also increased risk for ectopic pregnancies is an incredibly serious risk. PID is a serious syndrome. And here in San Francisco, we forget that having gonorrhea, chlamydia, or syphilis increases your risk of acquiring HIV 3 to 5-fold unless you're taking PrEP. We have a pretty high PrEP to need ratio here in San Francisco, but that is not true globally and not true in other parts of the country. So these are not syndromes and infections without consequence. All right. So San Francisco is always a special place. We are special in our rates of STIs. So this is comparing rates of chlamydia, gonorrhea, and early syphilis in San Francisco with those in LA. So San Francisco is this kind of, I don't know, teal. LA is orange and New York City is green. And you can see that for gonorrhea and early syphilis, rates of those in San Francisco far surpass those in these very, very large cities. And for chlamydia, we're almost as high as New York City. So we got them. So interestingly, there's also been a slight decrease in annual incidence rates for chlamydia, gonorrhea, and syphilis in San Francisco residents between 2018 and 2023. I think, does this, I don't really have one. Okay, so, clearly there was the COVID effect in 2020, like everything went down. Some of that is fewer infections, some of that is less testing. That effect seems to have lingered somewhat since then. Rates never returned to pre-COVID levels. And then in 2022, certainly for chlamydia and early syphilis, and even a little bit for gonorrhea, they started to come down again. So what's going on there? I think, first of all, I don't have the answer, but there's some interesting things to see. So clearly there's an inflection point at 2022. And we're going to talk about the effect of doxy-PEP on citywide STI rates in a minute. It is tempting to say that there was some change that lingered after COVID, whether it is really decreased testing because people are still having difficulty accessing care and testing, whether it's behavior change. I don't really know, but something seems to have happened and bears watching. And that's as much as I'm going to say about that. Nevertheless, even in 2023, our rates are still super, super high. Okay, so biomedical prevention. So biomedical prevention of STIs is not a new idea. It was tried in World War II in GIs, giving them this little kit where they would inject an extremely nasty suspension of basically mercury and sulfathiazole into the urethra. And they were also provided condoms. And then more recently, in 1979, there was a prospective trial of minocycline PEP versus placebo for men after sex with a sex worker, quote, in a Far Eastern port. It's just kind of amazing. And it was very effective if the MIC of gonorrhea, the MIC to minocycline in gonorrhea was less than or equal to 0.75 mics per mil. It was less effective at higher MICs. And this is a foreshadowing of what we're seeing in the modern era of tetracyclines and gonorrhea resistance. So biomedical prevention of STIs is not new. So the initial study that suggested that doxycycline would be a promising biomedical prevention tool for STIs was actually a study of doxy-PrEP in LA, published in 2015. And this was a small study that randomized men living with HIV to daily doxy-PrEP, 100 milligrams, versus an incentive. It was only 30 people. The primary outcome was getting any bacterial STI over 48 weeks, and that was decreased by 73%. The sample size was not big enough to show efficacy against specific STIs, but this was a very promising early study and really kicked off the era of doxy as biomedical STI prevention. So that led to the first large-ish study of doxy-PEP. This was a tag-on study to the IPERGAY event-driven HIV PrEP study in France. And the regimen that was studied is exemplified here. Sex without a condom is 2 smiley faces and a heart. That includes oral sex. And the recommendations for that were to take 200 milligrams of doxycycline within 24 hours of sex and up to 72 hours after sex. So here you see various variations on that theme. On the top line, the person has sex on Saturday. They should take their doxy the same time or within 24 hours on Sunday, but they could wait until Tuesday. Similar scenario on the right. And then on the bottom, you have someone who's having very frequent sex. They should take their doxycycline basically daily, but no more than once in a 24-hour period. They could take their last dose up to 72 hours after their last sex. And this is really the regimen that has become the doxy-PrEP regimen. So this is a slide summarizing the 3 big doxy-PrEP studies. So the IPERGAY one I told you about, doxy-PrEP, Dr. Lutkemeyer is here in the audience, was one of the PIs, and then the doxy-VAC study back to France. And all 3 showed some outcomes that were strikingly similar for syphilis and chlamydia and somewhat divergent for gonorrhea. So you see significant decreases in chlamydia, 70%, in IPERGAY, up to 88% in doxy-PrEP, 84% in doxy-VAC, syphilis, 73% decrease in IPERGAY, 77 to 87% in doxy-PrEP, syphilis, 84% in doxy-VAC, and really variable results for gonorrhea. There was a non-significant decrease in gonorrhea in IPERGAY. There was a significant decrease in gonorrhea in doxy-PrEP, although it was less than the decrease in syphilis and chlamydia, so 55 to 57%, not the 65% in the case. And then in doxy-VAC, and I'm not going to go into the details of what doxy-VAC was, but in the doxy arms of doxy-VAC, there was a decrease of 33% in gonorrhea. So at this point, it seems doxy-PrEP is extremely effective against syphilis and chlamydia and somewhat variable against gonorrhea. Okay, well, so those were in MSM and trans women. What about cisgender females? And why cisgender females? Well, globally, the burden of chlamydia and also the consequences of getting chlamydia are much higher in females, and particularly young females, and that's true in San Francisco as well. So in 2023, rates of chlamydia in San Francisco are the highest in younger women, especially Black African-American younger women. And we see similar disparities for gonorrhea as well. So the stakes are quite high, and it would be really great if doxy-PrEP worked in people assigned female sex at birth. Unfortunately, the one randomized trial to date, the DPEP trial in East Africa, very well conducted study, did not show efficacy for doxy-PrEP. And this was shocking and very unfortunate. And it turns out that it's very likely that as in some of the early studies of HIV PrEP, adherence was really, or non-adherence was really driving this result. Up to 44% of people assigned to doxy-PrEP may not actually have taken any. And these results were produced in Monica's hair lab. Okay, so that leaves us in a bit of a pickle here. What do we do about doxy-PrEP in people assigned female sex at birth? There's good biological plausibility that it should work, particularly for chlamydia and syphilis. So doxycycline 200 milligrams after sex reaches multiple fold higher MICs than are necessary to treat syphilis and chlamydia in the female reproductive tract and maintains those levels for a very long time. So there's good biological plausibility that it should work, certainly against chlamydia and syphilis. So what do we do? What do we say to someone assigned female sex at birth who is at high risk for STIs and might benefit from doxy-PrEP? Well, these are guidelines. On the left, you have the CDC guidelines. CDC provides grade 1 recommendation for doxy-PrEP, and their bottom line is to counsel all gay, bisexual, and other men who have sex with men and transgender women with history of at least one bacterial STI during the past 12 months about the benefits and harms of doxy-PEP. So they focus on people assigned male sex at birth, and they really prioritize people who've had an STI in the prior year. There is wide divergence of doxy-PEP recommendations nationally, globally. I don't have time to go into all of them. It's actually very interesting. This is what we put out in San Francisco for citywide guidance in 2022. Basically, we made a recommendation for doxy-PEP in cis men, trans women, and other gender diverse people who were assigned male sex at birth and who've had condomless anal or oral sex with at least one male partner and a bacterial STI in the prior year. So that's the highest tier recommendation. And those were people who would have qualified for the doxy-PEP trial, okay? Slightly less strong endorsement for tier 2, so offer doxy-PEP using shared decision-making to cis men, trans women, trans men, and other gender diverse patients of any sex assigned at birth who've had at least 2 sex partners in the last year, regardless of STI history. So they would not have qualified for doxy-PEP trial, but we think they're at elevated risk. And then we say more data are needed on the efficacy of doxy-PEP for vaginal or front hole protection. We talk about the results of the DPEP trial, the possible biological plausibility for doxy-PEP use, and really counsel people on an individual basis. So that's where we are with that. In addition, we counsel all of our people we're offering doxy-PEP to on what we know about the efficacy. We have started to warn people that it may not be as effective against gonorrhea as against chlamydia and syphilis, because we don't want them to get gonorrhea and then throw their doxy-PEP out the window and say it doesn't work. And we also talk about what is known and unknown about the impact on the microbiome and what is known and unknown about resistance. So what have we seen in the quote unquote real world? So these are data from Magnet on the left and City Clinic on the right. Both clinics have seen significant and large decreases in chlamydia, comparing people eligible for doxy-PEP pre and post, who started doxy-PEP and who didn't start doxy-PEP. So people who did start doxy-PEP saw 67 to 90% decreases in chlamydia, 56 to 78% decreases in syphilis, and insignificant decreases in gonorrhea at both sites. And then Maddie Sankaran, who's an epidemiologist in the department, did this incredibly cool ecologic modeling study looking at predicted syphilis and chlamydia rates in MSM and trans women in San Francisco versus what we actually saw in those populations in San Francisco before and after the implementation of citywide guidelines. And there were significant declines in chlamydia and syphilis and not in gonorrhea. Again, these are modeling studies. It's ecological data, but it's very compelling. And this is just a teaser. A couple of weeks ago in JAMA Internal Medicine, Maddie's study was published alongside a very large observational cohort study from Kaiser showing impressive decreases in all 3 STIs in people in their doxy-PEP program. I'm going to leave it to Franco and Stephanie to talk about this at their upcoming grand rounds here if they decide to. All right, so what about antibiotic resistance in doxy-PEP trial? I'd sort of like Annie to come up here and talk about this, but she's not. I'm not going to make her do that. So the issues around antimicrobial resistance are sort of the major questions that have bubbled up are, does doxy-PEP drive increased tetracycline resistance in Neisseria gonorrhea? So in doxy-PEP, there were slightly more incident cases of tetracycline resistance in people in the doxy arm versus the standard of care arm. Numbers were really too small to say anything about causality. More on that in a minute. What is the effect of doxy-PEP on the carriage of other more lethal pathogens, particularly Staph aureus and particularly MRSA, because we use doxycycline for staph treatment and MRSA treatment. And in doxy-PEP, it looked like there was a reduction in staph colonization and a small absolute increase in doxy resistance compared to baseline in those in the doxy-PEP arm. And MRSA prevalence was very low in both arms and was unchanged with doxy-PEP use. So small numbers, somewhat encouraging results. And then the other question is, well, what about doxycycline resistance mutations traveling with other resistance mutations to more pathogenic bacteria, to more, and affecting other antibiotics that are really life-saving? We know that gonorrhea is a very gregarious bug. It shares its genes with other bacteria via plasmids. And could we be driving the transmission of drug resistance from gonorrhea to other pathogens? All right, so first question is, what about doxycycline or tetracyclines driving a resistance mutation? So this is data from Bob Cohn in the department, and it's plotting doxycycline prescriptions at City Clinic in the black line over time from 2002 to now, versus percentage of gonorrhea isolates that had tetracycline resistance. And you can basically see that the more doxycycline you prescribe, the more tetracycline resistance you get. That's really not that surprising. The shades are important. So the light brown is low-level tetracycline resistance. The more dark brown bars are high-level tetracycline resistance, mediated by TET-M, which is a mutation that basically boots doxycycline off the ribosome. And again, you can see that we saw a sort of the emergence or the rise of high-level resistance around 2021, which kind of coincides with changes in STI guidelines in 2019, 2020, favoring doxycycline over azithromycin for the treatment of chlamydia and NGU, and also recommending treatment for MGen that is based on doxycycline followed by moxifloxacin. So we see a rise in high-level resistance then, and then we see a rise in high-level resistance following the introduction of doxy-PEP in San Francisco. So concerning, but the bottom line here is the more doxycycline you use, the more resistance you get. And I'll remind everyone that we don't use doxycycline first line for gonorrhea. And globally, the horse is out of the barn for doxycycline as a treatment for gonorrhea. There is so much resistance to tetracyclines in gonorrhea globally that, frankly, I was surprised that it worked in doxy-PEP. So there we have it. So then I think the most concerning question about doxycycline resistance driving, the most concerning question about doxycycline antibiotic resistance is, does it drive resistance in other bacteria to other antibiotics? So this is a really, really great study by Victoria Chu, who's here. This was presented at CROI, and it was recently published in Nature Medicine. And I really, really encourage people to read that Nature Medicine article. It's beautifully written, it has a great summary of tetracycline resistance and how it's studied in the gut. So this was looking at comparing looking at the resistome, so the microbiome, the gut looking at antibiotic resistance mutations in the gut microbiome as a possible reservoir for creating multi-drug resistant gonorrhea. So they did metagenomic sequencing, and they looked at the presence of DNA and also gene expression, so the presence of RNA. And what they found was that there was a lot of tetracycline-resistant DNA at baseline before anyone started doxy-PEP. And these were all participants in the doxy-PEP study. And also at follow-up. And that was both in the standard of care and the doxy-PEP arm. So there's a lot of tetracycline resistance in the gut microbiome to begin with, okay? Tetracycline-resistant expression did increase in those in the doxy-PEP arm versus standard of care. Again, not that surprising. The more doxy you use, the more resistance you're going to get. Luckily and reassuringly, there was not expression of antimicrobial resistance genes to other antibiotic classes with doxy-PEP use. So I think that is early and encouraging data against doxy-PEP driving multi-drug resistance. And I have 5 minutes. Okay. All right. What about doxy-PrEP? So doxy-PrEP is taking doxy every day, whether or not you're going to have sex. So a couple small studies in Canada suggest that it works quite well. There's a much larger study called DISCO that's comparing doxy-PEP to doxy-PrEP, and that may answer that question. Also reassuringly, there was a small study of doxy-PrEP use among female sex workers in Japan that showed very high efficacy. And this is a twofer. One, doxy-PrEP, seems to work. Two, doxycycline for STI prevention seems to work in people assigned female sex at birth. So I think encouraging news on both fronts. Wow, should I even do this case? I'm actually not going to do the second case. We have 5 minutes. Let's have questions.
Wonderful. Thank you so much, Dr. Spinelli, Dr. Bacon. That was fantastic. We will take some questions from the audience. Can you just go back one slide? Yes. Go back one slide.
I very much like this slide. All right. Do you have Casey, do you have a question about it, or you just? Okay, got it. Yeah.
Can you update us? That was an excellent talk by both of you. One question for each of you. Can you update us, Oliver, on the upcoming study or the ongoing studies in women for doxy-PEPs and what we should, any considerations that we should have for women? And then for Matt, I know the CDC did not take out we thought that they wouldn't do HIV RNA testing every 2 months on CAB, but can you talk to us about cutoffs and our considerations here at Ward 86, like when we start getting, is there a cutoff that you get worried about?
Yeah, so Janelle Stewart, who did the DPEP study in Kenya, is leading a large multi-site trial called Foxy-Doxy, Foxy with 2 X's for 2 X chromosomes, very clever, haha. And hopefully this will settle the question of efficacy in people assigned female sex at birth. They are supposed to start enrolling in 2025 this year. Fingers crossed. I personally, based on the biological plausibility and this study, if we see so we already talk about doxy-PEP with trans men, because the trans men we see at City Clinic have very, very high rates of gonorrhea, chlamydia, and syphilis. It's a very small number of people, but they're at high risk, and I have no problem giving them doxy. It's safe, right? And it may be effective. For people, for cis women, if they're at very high risk, we do discuss it on a case-by-case basis, and I'm in favor of doing it. But we really would feel better about doing it and certainly changing our citywide guidance if Foxy-Doxy shows that it's efficacious.
So the question was about if there's a viral load cutoff we'd use. I think it's challenging for patients to accept that we have a cutoff. Maybe long-term, I'd like to switch to the qualitative RNA. I have to talk to Jeff about that. It was an assay that was designed for diagnosis, whereas the assay we're using is now allowed to be used in that way. But I have to dig into the data, but I have a sense that maybe false positives are going to be less likely with the qualitative RNA. I don't know if Oliver has.
I don't.
We have 2 questions online. So the first question is, any data on non-chlamydial, non-gonococcal urethritis reductions in folks on doxy-PEP, either in the trials or in the real world?
Please ask The doctor in the second row.
So in the DoxyVax study, they saw a 50% reduction in MGen, which is a big cause of NG, NCT, urethritis. But it was a little funny because they sort of took all comers, and that analysis was a little funny. So I think we all want more, including we're analyzing data from our study on MGen. It is tricky there, but I think at the end of the day, Doxy is not a good treatment for MGen. We know that. They need to do Doxy and then Moxy. It can bring the bacterial load down, but then you have to effectively treat it. So remains to be seen. And then looking for other causes of NGU, I haven't seen good data on that, only for MGen, but I think we need a little more to understand it. And I just want to add one thing about Doxy. If I'm correct, I think they're looking at both taking it as Doxy PEP as well as a single dose. Tell me if I'm wrong, Oliver, on like Monday, like a weekly dose that is PEP, but to avoid, do you have to take it that's on demand, but maybe the Monday morning, follow up for the weekend. So that'll be very interesting to see if that alternative dosing strategy is effective.
Okay, one more Doxy PEP question. So thoughts on how Doxy PEP might affect the rate of rise of our syphilis titers in folks who have a history of syphilis. We're used to seeing the 4-fold rise. Should we have greater concern when we see a 2-fold rise? What are your thoughts?
Nobody knows. Not even Khalil Ghanem knows. And he knows everything there is to know about syphilis. So the concern is that intermittent doxycycline use will blunt the 4-fold rise in RPR titers that we use to say this is a new case, particularly in someone who has a who's serofast, right? And is always at 1 to 4. Will they bump to 1 to 16 or not? Will they bump to 1 to 8? It's a concern. It seems to be a theoretical concern at this point. We're trying to figure out how we would study that. I think it's really scenario specific. If someone has manifestations of primary or secondary syphilis and a 2-fold rise in their titer, you're gonna treat them anyway. So that's not a problem. The problem is really is this early latent syphilis or not? And I don't know exactly how we're gonna answer that question, but it may be a theoretical concern.
Okay, that's it. Wonderful. Thank you so much.